Okay. First case is a gentleman who has a history of dextromethorphan abuse. He's had multiple hospitalizations for this in the past. He's found in a park, altered and ataxic, and apparently his friends were concerned because they thought he was just drinking, and he told them that he took a bunch of Corsedin as well. He usually does this at home in his apartment by himself, so he's not out with people, and for whatever reason decided to do this in the park. The product he took has dextromethorphan and chlorpheniramine listed as ingredients. In the emergency department, he's tachycardic, he's hypertensive, he's got dilated pupils, he's got tremor, clonus, and hyperreflexia, and he's sweating pretty profusely. So I'm just going to pose a question to the group in terms of what is the difference between dextromethorphan and chlorpheniramine intoxication, and what do you do for this overdose? This is a call I received in an overnight case. The patient had come in, and the exam was what I was given. So let me raise your hand if you have comment or thoughts, or otherwise I'll start calling on individuals. See, what about someone from Emory? You want to comment?
So with chlorpheniramine, we're worried about anticholinergic type effects. Dextromethorphan, in addition to having some opiate-like effects, can also affect serotonin. So those are some of the differences, between the two agents.
Well, dextromethorphan, while having an opioid-like structure, doesn't really have classical opioid-like effects. Some of the maybe sedation potentially can mimic that with an opioid, but other than that, in my experience, it doesn't really look quite like an opioid. You're right. Yeah, the chlorpheniramine is anticholinergic. Certainly, did this patient look anticholinergic? The sweating, tachycardic, agitated, maybe some of the features. Does anybody have any other thoughts? I'm going to mute you back, Emory. Henry, what about you?
To me, I mean, like you said, this patient sounds like they're somewhat serotonergic with the tremors and the clonus. So I think they sound like, regardless, with the diaphoresis, tachycardia, all that, they seem benzodiazepinepenic, and that would probably be my go-to treatment for the patient.
Good. Yeah, I think, we have the packet with chlorpheniramine labeled on the ingredients, but, went over this a couple of times with the provider at the bedside. That patient was clearly sweaty. They also had bowel sounds present, so certainly sounded, and had the clonus, hyperreflexia, mydriasis. It sounded more serotonergic than really anything that I was going to do with the chlorpheniramine. So benzodiazepines, I agree, would be one of the things that you would use to treat this patient potentially. This labs come back. Patient has an elevated CK a little bit in the thousands. White count is a little elevated. The creatinine's up mildly at 1.5. The bicarb is a little bit low. And these symptoms start to improve with fluids and benzodiazepines. The agitation, which was really more restlessness and anxiety, that settled when the lights were dimmed and he was just let alone. Overnight, his tone, which was increased mostly in the lower extremities, and he had a tremor, improves after some benzodiazepines. He got 2 doses of 10 milligrams IV diazepam initially, followed by some lorazepam. It was changed. Basically, I think the hospitalist team changed to benzodiazepine, not for really specific reasons. In the morning, he's awake. He has a little bit of clonus, but he's not febrile. He's not rigid. His heart rate's in the 80s. His blood pressure's a little bit up. He's improved. He's not hallucinating, and he says, I have some thoughts about how to treat this. And this is what I'm interested in, what people think about his particular question. A little bit about his background before we talk about treatment potentially. He has a history of marijuana, cocaine, opiates, polysubstance abuse, medications as well, including some sedatives at times. Currently, he's only really using THC marijuana pretty much daily, and then he's abusing the dextromethorphan. And he reports that he does usually use it with chlorpheniramine, and he says that he doesn't usually get the chlorpheniramine effects. He actually knows what those are. He knows that it could stop him from sweating and his temperature may go up, but he says, I'm always usually sweaty when I take this, and it doesn't really seem to have done anything. In fact, I've tried it both ways, and I seem to get a better high when I add the chlorpheniramine to the dextromethorphan. But I really need to stop doing this because I'm on parole and they're not very happy with me, and I've got to stop doing this. He used to take dextromethorphan daily. Now it's only intermittently with binging. Despite the report of drinking alcohol in the park overnight, he didn't have an alcohol concentration, and he says he wasn't drinking. It's really the marijuana and the dextromethorphan. So before I get into what his thoughts are, does anybody have any thoughts of treatment? He's interested in something in particular to either affect craving or dextromethorphan. He hasn't really thought about the marijuana. And he's clearly doing better from the overdose. So at this point, it's really pharmacologic management for dextromethorphan use disorder. Joanne.
So one thing people have been bringing up here in Minnesota is doing low-dose buprenorphine for patients who are DXM users. I don't know how I feel about that. Like, one of my thoughts, and I haven't tried the same way, is using something with some NMDA antagonism like topiramate. But those are two options that could be considered for him.
That's interesting. I've not thought about buprenorphine or heard about that, but the topiramate makes some sense. I use that off-label for cocaine craving, a little bit different mechanism. Keith Burkhart, you have your hand up.
Yeah, I just was thinking of one of my favorite go-to drugs, like NMDA upregulation from alcohol withdrawal and agitated delirium type stuff. I love a little bit of that low-dose phenobarbital. I'm not now anymore, and be curious to hear some other people's thoughts as well along that line.
You mean for the intoxication or chronically for the patient to maybe keep them?
Well, it's more intoxication. I guess I was focusing on that acute agitation. The serotonergic effects, and I think this might be the combined serotonergic and NMDA actions in that as well. So it's not just a pure serotonergic type of syndrome, I don't think. So that's why I was, thinking to go along that line. Even in serotonin syndrome, as we know, cyproheptadine doesn't work very well. The benzodiazepines, except for in milder cases, don't really work too well. So just some of my thoughts on it.
Those are good thoughts. It's a good point that the dextromethorphan has other pharmacology that may be involved in the intoxication, as well as potentially the chronic abuse of this. And then there's an anticholinergic agent that he's using pretty high doses of. He reported he usually takes, it came out to just under a gram, 900 and some milligrams, and I think that's basically the amount that was in a certain number of sheets or packets, and that's of the dextromethorphan and then the related chlorpheniramine. Anybody have any other thoughts on medications, either acutely or chronically? He did well with benzodiazepines, but I think phenobarbital is a reasonable choice if he's more, initially he's more agitated. I probably wouldn't continue that long term, but initially for the intoxication, very reasonable.
Since you still have me unmuted there, Tim, yeah, well, I remember taking care of a lot of cyclic antidepressants overdoses, which, as you know, are very pro-serotonergic, sympathomimetic, and anticholinergic, amitriptyline overdoses. And I'll just say that in some of those cases, even though we always thought of amitriptyline or so being so anticholinergic, you can have anticholinergic that's on board and still have the sympathomimetic or the NMDA effects and that win out. So I would say that there's still a good chance, as you said, this guy's history, I think he probably did have a significant amount of chlorpheniramine on board too.
Good, thank you. Any other comments or thoughts? Any differences in the management? Well, we looked at dextromethorphan abuse cases seen by the tox service, and it was interesting to see in all the age range was from the young accidental exposure in pediatrics to usually mid-teens to later 40s and even 50s that were chronically abusing it. And it seems it's an interesting medication. I guess availability is some of it, but it's not just the availability over the counter, non-controlled and non-restricted, that's why people abuse it. There seems to certainly be some people that have an affinity for it and they take it. This gentleman described specifically having an antidepressant effect, that he felt his anxiety go down and he just felt less depressed when he chronically took it. And he also conceded that he was going for the dissociations, the hallucinations, and the euphoria that he had when he took a big dose. And he described his favorite activity then was to lock himself in his apartment in a dark room and just kind of go with the hallucinations. This time he was out in the park, and he thought that that was one of the reasons why he ended up in the hospital, is he thought people saw me doing weird things and they panicked, and then in the hospital it made it worse. So, but when I've worked with these patients, we've had sometimes problems with their other medications. The dextromethorphan is serotonergic, and there's a lot of serotonergic psychiatric medications, the SSRIs, the SNRIs, some of the atypical antipsychotics. And this gentleman actually understood that. He said, I know it will cause serotonin syndrome if I take dextromethorphan with it, but how about you put me on an SSRI or an SNRI? It happened to me once in the past, meaning he took extra dextromethorphan not realizing what would happen. He ended up with severe serotonin syndrome with fever and rhabdo and acidosis. He was very sick. He said, I think that I would avoid using it if I knew that that was going to happen. So he's thinking of this as maybe like an anti-abuse type effect. The SSRI or SNR may be actually treating something, anxiety to antidepressant, so there may be other beneficial effects. But I'm wondering what people think. Would you be willing to prescribe an SSRI, SNRI, thinking that this is an aversion therapy in a sense for this gentleman?
This is Joanne. I'm not sure about the aversion therapy because we haven't had very good success with abuse in non-supervised situations, and like people do things that get themselves in trouble all the time without regard for the consequences, like inject and then get septic and need a heart valve, and it doesn't stop them from using. Another option, I think that we did this in one patient, was using extended release naltrexone for cravings, just to see if it had some effect. It didn't seem to, but this was a pretty chronic user of DXM that didn't have any motivation to stop using.
That's a good thought. I've tried naltrexone in the patients that I didn't see much improvement as well. Michael Marlin, you have a hand up. What are your thoughts?
Yeah, I was just going to second what she said. I don't, anabuse has limited efficacy, and in this, I'm not sure if it's more the the serotonin agonism he wants, or it's the NMDA antagonism. So you have that real risk of putting him on something that he's just going to go right back out and use and possibly have a worse outcome being on an SSRI. I was going to add too, chlorpheniramine, if I'm not mistaken, is one of the antihistamines that has serotonergic properties itself. Yeah, I would be I'll be reluctant to put him on an SNRI or SSRI for that matter.
Yeah, those are good comments. I think, although the comments about antabuse, I still find useful in only certain populations, when either someone wants to bring their partner, significant other, parent into their treatments, maybe to help rebuild trust with alcoholism. They, get them to maybe administer their dose, and they can be involved. They know they're taking it, they're going to get sick if they drink. But if the patient doesn't want to take it, they're not going to take it. Some of them may drink on top of it. I've also found usefulness when somebody's on opioids, methadone or buprenorphine, sometimes, and won't stop drinking, has really bad consequences, and I'll prescribe the antabuse that they have to come in and take with frequent observed doses with buprenorphine. And one of our opiate treatment programs will put the disulfiram in with the methadone, so that they're taking it every day to continue the methadone, and has even made arrangements with the other OTPs so that they can get 7-day dosing. So, and I've had patients that I'm able to keep on their opioid agonists with the antabuse that aren't drinking, and we're checking, ethyl glucuronide. So there are cases in the right patients, fully informed that something bad will happen. I think that might be useful. This guy, I agree. I don't think I would put on an SSRI or an SNRI. I mean, he's had the reaction. He seems pretty impulsive. I don't know him well, but I think his request was interesting. He said, maybe you can guess where he got his pharmacology training from. He said, since I was 12, I spent hours a day on Arrowhead every day. I was reading everything that came up about the experience reports and about the drugs and medications. He said I learned my pharmacology from Arrowhead. So, and since then he spends a lot of other time. So this gentleman was referred to treatment and follow-up, but we didn't put him on an SSRI or an SNRI or anything. And any other thoughts about this case, or we'll move on? Remember to raise your hand, and I'll unmute if you have a question or comment. Or you can also send a chat in, and if you don't have audio. So we're going to switch directions a little bit. The second case is an interesting patient who came in unresponsive. He was gardening. He's an 82-year-old who had been gardening all day and then came in from the heat, and his family found him unresponsive, and bradypneic meiosis. EMS noticed that this looks like an opioid, and his family also had gotten his medications out, and he's on an opioid. He's on oxycodone. He's on sustained-release oxycodone. Not huge doses, but moderate doses. He's also on baclofen, gabapentin, ampicillin, metoprolol, and sertraline. He wakes up, responds to the naloxone initially, although he's a little bit confused. In the emergency department, he has a little bit of recurrence of sedation, but doesn't need additional naloxone. His heart rate, blood pressure are essentially normal. His labs come back showing that he has some acute kidney injuries. Creatinine's 2.5, and it hasn't been elevated in the past, maybe a little bit for his age, closer to the ones. His glucose is normal. His BUN is 28. Sodium slightly up. His white count was a little bit up. I don't have that here. His meds, family swears that he's taking them normally. He didn't confuse them. He took his meds earlier in the day. He hasn't run out of his oxycodone in the past. He hasn't abused it. There's no other opioids. So I'm wondering, what are your thoughts on why he had opioid intoxication? Or what happened? I'm going to call on a couple people. If I don't, raise your hands. Otherwise, how about Dr. Guide, AJ?
Hey, Tim. Thanks for your question. You know, one thing that goes through my head is I wonder, is this guy at all possibly on a fentanyl patch? Because it's warm, he may have, let's say if he was on a fentanyl patch, he may have had a sudden, like, rush of blood flow to the skin and then had increased absorption from that. That's the one thing going through my head.
Well, I think that's a great thought. The patient wasn't prescribed a fentanyl patch, but I think that's certainly looking for other sources of opioids. The heat, he's out exercising, very reasonable consideration.
Tim, this is Joanne. What was his creatinine again?
It was 2.5.
And
that's up from 1. Sorry, what was it?
My thought would be if that's a change in his renal function, that he's on several medications that are renally cleared, and perhaps one of them is building up in his system, including the oxycodone.
That's a good thought. Let me go back to his medication list. He's on the oxycodone. I'm sorry, who is that?
This is Michael Marlin. I know we've had issues, especially with nephrology, asking certain more Medirex of baclofen, and I wonder if he's had a synergistic effect and the baclofen's accumulated with his AKI. I mean, it's largely excreted unchanged.
I think that's a good thought. There's a couple medications, as both you and Joanne had pointed out, that are renally cleared. Baclofen, gabapentin is also renally cleared. He's on both baclofen and gabapentin. The oxycodone, usually don't see much of a problem, unlike morphine or high doses of morphine. But maybe someone can correct me if I'm wrong. I've just not seen as much of a problem with variations of creatinine with oxycodone, but definitely with baclofen and gabapentin. And, you know, that's what I had thought. I mean, he acutely bumped his creatinine. He's getting dehydrated. He took his baclofen and gabapentin earlier in the day. And, you know, I see these used as opioid potentiators all of the time, and that, you know, they're taken to kick in the effects with opioids. Gabapentin, pregabalin, baclofen. So, you know, they're making the effects stronger. He came in with opioid effects. He's a little bit confused, so maybe he had some residual baclofen or gabapentin, and I thought, you know, that was potentially a part of the problem. Keith, do you have another comment? Hand's still up. How about Ingrid? I'm going to unmute you. Do you have any comments or thoughts?
Well, I guess quite apart from the fact that these are addiction rounds, just going back to emergency medicine, I would be worried about at his age and having been outside, whether his baseline and his mental status is more related to a heat illness, you know, heat-related illness. And, you know, I mean, back in the day when we were giving naloxone right, left, and center, there was often a non-specific response to naloxone in situations that you wouldn't have expected it to occur. So just because he responded somewhat to naloxone, does that really mean that it's because of the opiate, that, you know, that it's opiate related? So I'd want to know what his temperature was and his degree of dehydration and whether he would have just have improved his fluids and cooling.
No, those are great points. Certainly looking for other medical conditions. He'd been out all day, dehydrated. You know, he's had enough of an effect on his kidneys. He certainly may have either heat-related or other effects that we don't want to miss. I would have expected him to get some. And he is 80, he's 82, yes, he's in his 80s. And I would have expected some effect from the naloxone anyway, even, you know, in overdoses where somebody is on a chronic stable opioid but takes something else that may be causing sedation. You'll get an effect if you take away the opioid. So, you know, so this naloxone reaction is not surprising. But, you know, I think potentially I wanted to talk about this case as potential opioid potentiators and, you know, interactions with opioids. I think, you know, baclofen, gabapentin are very common culprits that I see at any given time on our consult service, there's 1 or 2 people that are either taking one of those medications in overdose, often on opioids, but sometimes not on opioids. And I'm wondering, what are other people seeing as opioid potentiators? What are patients using? And what's been your experience with baclofen and gabapentin in patients on opioids? We've got a couple newcomers. Holly Russell, Dr. Russell, you prescribing Suboxone. You see in your clinics patients taking extra gabapentin or baclofen, or are you worried about those medications with opioids?
We found out had been selling for gabapentin. A patient who has been, taking extra of her gabapentin with Suboxone. So I think, like, my interpretation of that is kind of like the word is getting out that you can take extra and possibly, feel something different than you would normally feel with just taking your regular dose of Suboxone. And certainly the street value is something that's of concern as well, although that's not related to this particular case. I think it's something that we're going to see more and more of, is my expectation, kind of. My thoughts from this case were what the previous woman mentioned about, his age and medical conditions. That certainly seems like a very high clinical likelihood of having an effect here, especially with the AKI and dehydration and heat injury.
Good, thank you. So, patient had his gabapentin, baclofen, oxycodone all held, and he did well with fluids and just simply supportive care. And the team had wondered about restarting the medications. I usually don't recommend restarting gabapentin or using gabapentin, baclofen. They have similar overlapping effects. And I thought potentially we've got a safer opioid. This gentleman had chronic arthritis. He also had some massive renal masses, as well as he's being worked up for potentially cancer, although it wasn't clear at the time of the case if it truly was cancer, what the masses were. So he had potentially some reason to have, and he's been chronically on opioids and tolerated them except for this recent episode. But I thought we might try buprenorphine and see if it's a little bit better opioid if he's going to need to continue. So I'm wondering, would anybody try or consider Suboxone or one of the formulations only for pain in this patient with no history of opioid use disorder and restarting the medication? When you see patients come in with potentially adverse effects from their opioids, whether it's from intentional use, abuse, or it's accidental and physiologic, do you look at putting them on potentially a safer opioid? What about Dr. Loomis? If your patients are...
So I think insurance coverage is also always something to worry about outside of the Butrans patch, and I guess it would be interesting to know his dose of the oxycodone to know if the patch, if that would be strong enough to cover what he had been getting with the oxycodone.
He'd been getting 10 of the oxycodone every 6 hours, and the sustained release oxycodone was 20 to 12.
So I would be a little hesitant with the Butrans patch maybe not having as much of an effect as what he'd been on. But I think counseling and making a shared decision would be super important around this.
That's a good point. Can someone tell me what the different formulations, or go through the different formulations of buprenorphine that are available for pain versus opioid dependence. Henry?
I mean, my understanding is that there's obviously, you know, Suboxone that we can use, that we use typically for patients who have opioid use disorder, as well as some pain, and we can certainly split that up for pain. There's obviously Subutex. From my point of view, the only real reason to be using that is someone with opioid use disorder who's pregnant. There's the Butrans patch, and then I believe there's a lower dose. Is that the Belbuca? Or is that the buprenorphine only kind of formulation that can be a little bit lower dose that you can use for pain as well in patients who aren't on as high of a dose as somebody with opioid use disorder. So that way you're not kind of having them, 2 milligrams, and someone who's relatively low opioid tolerance ends up being quite a large amount. So you could prescribe them, these kind of lower dose formulations for pain. Having said that, I don't really have any experience with that. The patients who I've been treating with pain also have an opioid use disorder, and we go with the higher doses.
Those are good comments. Those are some of the formulations. There's a couple of others, and as Dr. Loomis had mentioned, running into problems with insurance coverage for some of these. The typical treatment for opioid dependence in our area was Suboxone, the 4-to-1, 8/2, 2/0.5. Now they've got a bunch of different doses, 12/3, 4/1. We have Zubsolv, which is a little bit better bioavailability, that has bioequivalent doses, but at a little bit lower, and the pill is menthol. And they also have child-resistant wrappers, individually wrapped doses. There's Bunavail, which even has better bioavailability than the Zubsolv. I don't recall exactly what the dose increments are. I've not been able to ever prescribe that because of insurance restrictions. They have the bioabsorbable membrane technology that allowed for buccal administration. We also now, as of the last month, have a generic buprenorphine naloxone film that I've had a lot of patients automatically switch to, and got a lot of panic that it's not the same, it doesn't taste the same, it's not as strong, and that's just a recent. So we've got a generic film. There's also generic tablets that are available and have been out that are in the typical Suboxone dose increments. And then we've got the formulations only for pain, and from what I've seen, there's only 2 of them. There's the Butrans, as Dr. Loomis had mentioned, and then there's Belbuca, as Dr. Swoboda had mentioned. The Belbuca is sub-milligram doses. I think the highest dose available in Belbuca is just at 1 milligram, and in my experience, this has been more expensive than the formulations for dependence, and so, as well as the patch. And so if I'm writing for pain, or recommending someone prescribe for pain, we're often left with using the treatments for opioid use disorder off-label, and usually like the 2 milligram dose, depending on how high of a dose of full agonist the patients were on. There's some other formulations of buprenorphine that are out that are long-acting injectables, the Sublocade, which is the monthly injectable, 300 milligram depot of buprenorphine subcutaneously once a month, and then the Probufene, which is the implantable chip or the rods in the arm for 6 months. Each of these has indications and methods for getting people transitioned onto, and those, neither the Sublocade or Probufene are available from the hospital setting. Where I'm at is more of a clinic prescription. We've got a comment or a question from Dr. Al-Safani. Assad.
Hey, Tim. Yeah, Assad is our senior fellow. This is Josh King with the UVA group. I can't comment at all on buprenorphine versus oxycodone in this setting, as I'm not a pain or addiction doc, but just reinforcing your point about gabapentin, which is essentially solely renal cleared to the point where the maximum dose goes down by a factor of 12 when you reach ESRD. The most I use in my dialysis patients is 300 milligrams a day. I really think the gabapentin is the key here, and I wonder if that's, even whether or not his opioid is switched, whether gabapentin is not a good option for this patient if he's at risk for AKI in the future.
Thank you, Josh. Those are good points. The next, that, was kind of what, my perspective was as well. The gabapentin was DC, the baclofen was started at a lower dose, and patient was on board with trying Suboxone. He was actually still a little bit confused when we had started it, and the plan was to use that to potentially take the opioid withdrawal as a cause of kind of persistent mild encephalopathy versus is this just his improvement from the gabapentin and baclofen. And so initially we tried the Suboxone just to kind of take him out of withdrawal, see how it works, see what, not necessarily planning on continuing it because it was going to be effective for his pain, but it did work for bringing him out of withdrawal. He had the oxycodones held from admission, and this is the second day that he was in the hospital that we did the induction with a 2 milligram dose, and he did fine. Continued to improve after that and was very happy with his pain control on the Suboxone. In fact, he specifically commented that there were parts of his pain that just weren't ever quite taken care of and that something was different. And he was trying to figure out what it really was, but he was very happy with that. And it was interesting, I had him explain it to the team. And, in a situation like this, the patient's on board, but sometimes we have challenges with the primary care provider if they're not X-waivered, but less so in the last 6 months to a year. People seem more on board with and more familiar with buprenorphine. So we called the primary care provider, and the initial response was, well, I don't have the certification, but was open to prescribing it when we informed him that he could do this off-label for pain and maybe, he'd consider getting the X waiver. So patient did really well on this, had some medication changes, the gabapentin tapered, the baclofen continued, and then he's got this ongoing workup for some masses that may or may not have been at all related to the presentation. And I think his dehydration, renal failure, and the gabapentin or baclofen was probably, the culprit, maybe or may not potentiating the opioids, but certainly one of the problems with this creatinine being up. Anybody have any other comments or thoughts about this case, or I'll move on? Henry, do you still have your hand up from before, or do you have another comment?
Yes, I have another question or part of a comment. I guess my question was, what dose did you end up putting him on for, the buprenorphine in this case? And, do you have a rule of thumb that you use when you're trying to replace somebody, who's, who has a home regimen that you're trying to replace? I see different stuff out there. My general rule of thumb is kind of 2 milligrams of Suboxone is maybe equivalent to 20 of oxycodone, and so this guy's on 80, and I might have put him on 2 QID to see, if he's taking it for pain, to see how that works. But I've seen elsewhere where they say that 8 milligrams of Suboxone is equal to 215 morphine equivalents, which seems like more than I've noted in my experience. So I was just wondering if you kind of had a rule of thumb that you use for these dose conversions.
Those are great points. I think, in general, if somebody's on very low levels of opioids, mostly subjective symptoms, really not objective withdrawal, or they don't go into withdrawal, I'm not really going to consider using the off-label form of buprenorphine for the treatment of pain. They might be a candidate for the patch or something, or if somebody's off and on opioids, maybe has recurrent adverse effects, it'd start pretty low. Under the 2 milligram dose threshold. And this gentleman, I think, on 10 Q6, 20 Q12, he certainly could tolerate the 2 milligram dose of buprenorphine, and he did without any sedation. So we left him ultimately on the 2 milligram or 2/0.5 Q12 with recommendations if he has breakthrough pain during the middle of the day, that this could even be split further from the 2s to 1/2 TID or 1/2 Q6 hours, or an extra 2 milligrams could be added in the middle of the day. You know, similar to methadone, the analgesic effect is shorter than the effect it has on withdrawal and craving. So he left doing really well on 2 milligrams or 2/0.5 twice a day. His primary was going to follow up and continue him on that planned off-label, and we had a plan to continue with, you know, I mean, to adjust the dose for his primary if he had any other questions. You know, this isn't an uncommon question from the medicine residents and medicine service, is we've got an elderly patient or, you know, a patient who has chronic pain, and we think that they, you know, the opioid has a role or they do terrible without it, but there clearly are problems. There's sleep apnea, and they, you know, we think that, you know, they're at risk with the opioid at night, or, you know, there's other problems. Maybe they've had accidental overdoses, and we get a consult to evaluate for whether buprenorphine is appropriate or not. A lot of the pain services are just starting to really consider it as an option for pain, but they don't really, there's not very many of the providers that actually have a clinic where they're prescribing it. There are a couple in our system that are treating patients, but it's not very easy to refer them to get treated if they don't have an opioid use disorder. It's much easier if someone has an opioid use disorder to treat them in the context of the addiction, and, oh, hey, we can also treat your pain as well with this, just dose a little bit differently. Anybody have any comments or thoughts on that, or see that in their institution that's similar issues, or has anybody considered, you know, as part of their consult service?
This is Joanne. So I find that I have split up the dosing if they have sort of a painful condition. And I know I don't do much outpatient clinic, but I know in the outpatient clinic, many people are doing twice-a-day dosing, if not kind of changing it to that 3 times a day dosing if there's an indication to have it that frequent.
Got a couple of people that we haven't heard from. Any comments or thoughts, Chris Holstage? I'm going to move on to the next case, I guess, if we don't have any other. Ingrid, do you have your
No,
any
I don't
other
have
thoughts?
anything.
Okay. All right. So case 3. This gentleman has had a couple of admissions over a very short time span. He's on methadone, a 28-year-old who has been on methadone on and off for a long time, at least 10 years of methadone therapy, just after 18. And he made some comments about killing his father while at the opiate treatment program. And staff heard, and he's brought into the emergency departments with mental health arrest. I think the family had mentioned that they were concerned about him maybe taking some pills. Parents were in the ED with him, and they had commented that they had seen a lot of people changing pills and stuff that went on in the parking lot, that they were concerned. His father regularly drove him to the clinic because he's bought pills, taken things in the line, and overdosed in the past, and so he was trying to limit that. And anyway, he ends up in the emergency department. He's initially alert, and then starts to become disinhibited, and then somnolent, and then he becomes unresponsive. And this is over a very slow period. He's initially breathing okay, so he's just kind of watched on oxygen, but he becomes somewhat bradypneic over about 30-minute period. And when we had seen him, he's pale, bradypneic, mildly hypoxic. He's got some oxygen on, but it's kind of fallen off the face, and he's got subtle myoclonic jerks. His heart rate and blood pressure are mostly normal. There's a couple of readings of his blood pressure in the 90s, over 50s, 60s, but otherwise his vital signs are normal. And when he's stimulated, he wakes up. He's not lucid. He can comment, say something, but he rapidly falls back asleep if you don't give him external rubs. So He's got normal sinus rhythm, no QT prolongation. His labs come back essentially normal CBC. Thoughts on what he took? What happened? A gentleman with slow progression of sedation and respiratory depression who is methadone dependent had come in from the methadone clinic. What about Ron Kirshner? Do you have any thoughts on this case?
So he was maintaining his airway and oxygenating okay, hadn't needed any naloxone.
Well, he hadn't given naloxone. We thought about it. I mean, when he's bradypneic, but to this point, and that was certainly part of the thought, the plan. He doesn't have take-home methadone. He did get his dose. His dose is 115 milligrams.
Yep.
But
in the clinic. So he's just maybe a little more somnolent than normal, but his airway and his oxygenation are adequate.
When poked, but his oxygenation, his respiratory rate drops a little bit when he's not stimulated. He's pretty somnolent. He's gone from initially disinhibited and awake to unresponsive, essentially. So what else could cause this? Justin Corcoran, you have any thoughts? What do people take at the methadone clinic? What are some of the things that you see, patients coming in with overdoses? This wasn't a suicide attempt. This is just taking a bunch of extra pills potentially.
I'd be a little bit concerned that he got into benzodiazepine as well. You wouldn't normally expect a lot of respiratory depression with that on its own, but if he was co-ingesting with an opiate, you could see some respiratory depression there.
That's a good point. In fact, as we were talking with the family, his mom commented that he used to get these packages in the mail that he was ordering, she mispronounced it, but benzodiazepines from the dark web. And later, when he's awake, he confirmed that he hasn't recently, but had been getting clonazepam and atizolam. But when he did that, he had a huge problem. He said he overdosed much, much, much more. So that wasn't what he had taken, at least today. But benzodiazepines are one of the more common co-ingestions with methadone. Good. Dr. Malko, do you have any thoughts, comments on this?
I mean, I think in general the drugs of abuse are things that people are also using when we see them in clinic. I mean, things that are also sedating, like gabapentin, or there shouldn't be any concerns for Suboxone, because that would not be working so well with their methadone. I think benzodiazepines are a good idea. I think other than that, I don't have any other.
Hey, Tim, this is Joanne. Can you hear me?
Yep, you're on.
Okay. We had a couple thoughts here. One was if he had taken an edible with marijuana in it, those can have a little bit delayed onset. The other thought would be, was he on a medication that was inhibiting the methadone metabolism and then he changed it suddenly, or did he start a new medication that increased the effect of the methadone, or was there an error at the methadone program? So that sometimes happened in my program where they've accidentally gotten a double dose or the wrong dose, and that should be caught right away, but it is a potential risk.
Those are great comments. I think the error, I hadn't really thought about that, but the speed of his intoxication was very odd. I thought that this is very slow, and actually was wondering, well, maybe he got into something like valproic acid and checked his med list. He's not on Depakote or anything, because it was pretty slow. It wasn't, he sat in the ED for a while. We already talked about some of the other drugs that come up in opioid use disorder, gabapentin, pregabalin, and one of the hints was he's got, essentially sleepy, essentially normal vitals. He's got these little myoclonic twitches. So seeing that, the three things that I'm thinking are going to be, well, did he take Lyrica, pregabalin, gabapentin, or baclofen? And in fact, gabapentin was on his med list, but that wasn't what he admitted to taking. He admitted to taking a couple of Lyrica one line at the OTP, a couple of the 300s, and he was later, when he woke up, he confirmed that he had been in the past abusing clonazepam and atizlam, but doesn't really do that so often anymore, but he does occasionally take some clonazepam and alprazolam. It was interesting, before we had seen him, the ED team had decided to give him 0.04 milligrams of naloxone incrementally. They only gave one dose, and I think there was an error in communication between or ordering, give this IV, but it was given IM, so that's a real small dose IM. It didn't really do anything. Initially, there was, after hearing that he had been taking potentially clonazepam or atizlam, we used small doses of flumazenil, which he did respond to. So there was definitely a benzodiazepine there as well. He woke up with the flumazenil, but it was fairly short-lived in terms of the recurrence. We only gave 2 doses, and he, when he woke up with that, he confirmed that he had taken the pregabalin 300s, a couple of them, and he had recurrence of his somnolence, but he didn't have recurrences of bradypnea or the hypoxia, and he's admitted for monitoring. His parents are not happy with him. This is too many overdoses, and also he wants to kill his dad, so he cannot come home. And so he's admitted to the hospital with not clear disposition. The methadone treatment program will take him back, but they're a little hesitant with, all of the sedative use and the sedative overdose, and are considering a dose decrease. And so those of you on the phone that manage some methadone or are covering a methadone or an opiate treatment program, what do you do with a patient like this that has now overdosed and taken drugs that potentiate the methadone, had a couple of admissions, many admissions, it turns out, in the past with benzodiazepines and methadone, some near fatal overdoses. It turns out he's also intermittently using some heroin on it. Do you keep this guy on methadone? Do you try and take him off, get him on buprenorphine? What would you do if you got a call from the hospital trying to confirm his dose first and then finding out he's had another overdose while on the methadone?
This is Joanne. So what I've done in these cases where they've had multiple overdoses, lower the methadone dose some. That's one option. The other option has been converting them to buprenorphine, but it's always a little unclear to me whether buprenorphine is safer than methadone with benzodiazepines or not. So I'm not sure if that's helping them in the long run.
Yeah, I think from what I've seen, the data in buprenorphine or methadone with benzo shows that there's less severe outcomes with co-ingestions from Poison Center data, I think some RADAR's data, there's less fatalities associated with buprenorphine and benzos and full agonists. But so I think it would be safer. I don't know. This gentleman is on a higher dose of methadone and off of it uses a lot of heroin. And, I think the treatment program that has him on methadone is using a more of a harm reduction approach, that he's going to just do worse. There's a higher risk of killing himself off the methadone than on it, and we're aware and we'll accept that risk. But they did want to drop his dose a little bit until he developed a plan that that could be implemented to stay away from the sedatives. And some of that was to try and get him inpatient, maybe into a halfway house, and have very close follow-up with him. So the plan was to drop him to 80 milligrams from 115 milligrams at 5 milligrams decrease per day. He wasn't too happy about this. He's discharged on a Monday after staying in over the weekend, and he was to go to the social services office or a shelter after that, and he on that day has a court appointment as well, and it wasn't clear from reviewing the records if he was identified at the court appointment or again at the methadone clinic, the opiate treatment program, as becoming disinhibited and altered again, but he apparently took his bottle of gabapentin that he had picked up that we had recommended be stopped, but he had a prescription waiting and had an almost similar presentation where he became somnolent, encephalopathic from taking a bunch of gabapentin, this time on top of the methadone. This was more of a, yeah, I'm going to get high, but I'm really frustrated because I don't have housing and my parents are. He's very, very upset at them, and so we have another dilemma on what to do and how to help this guy, and he ultimately had a very similar discharge after watching him clear in the hospital, and he was going to follow up with the opiate treatment program, and it wasn't clear. I think they wanted to see him and talk to him as to what they were going to do, but unfortunately this doesn't bode well. They were going to talk to his prescriber for the gabapentin to make sure that that wasn't refilled, and hopefully put together a plan that he would agree to that would limit his use of all of these other substances so he could stay on methadone, but he clearly struggled. This is an interesting case. This is not this 2 overdoses in the same day, someone so impulsive and struggling like this is not as common, but we do see an awful lot of, whether it's heroin, yeah, I took some of my Lyrica or my Neurantins and boosted the heroin, or someone told me you'd kick in my methadone or even Suboxone, and it's just becoming a bigger problem. The pregabalin's controlled, but the gabapentin's not, although in New York there's a bill up for scheduling it, and I know some of the states have gabapentin scheduled, or at least showing up on iStop or the prescription monitoring. Is anyone from a state where it's showing up, where gabapentin shows up on the prescription monitoring program?
This is Joanne. In Minnesota, we have it showing up on it.
Anyone else?
It's amazing how many people are on it in our methadone program.
Yeah, no, there's studies from Europe and U.S. that 30 to 60% of opiate methadone patients will have pregabalin in the urine, and the clinic where I prescribe most of the buprenorphine patients that I have, about 30% started having gabapentin in the urine when we just added it on the immunoassay as part of one of the bundle tests, which didn't add an expense, but just allowed us to see who was using it but not reporting it, because it isn't scheduled. It's hard to find out somebody's using it unless they're taking it and obviously intoxicated or report, or you call every pharmacy the patient goes to. So it's very common, commonly abused. I'm wondering, and we've got a couple of other providers that prescribe Suboxone and various types of outpatient clinic practice, what your policy is for the gabapentin, and what you're doing in patients in general, especially Suboxone patients. Holly, you had commented, but Liz, do you have some thoughts? Liz Loomis?
Really we end up having multiple patients on gabapentin from a chronic pain background. Some of those patients are, have very normal behavior around gabapentin and are on lower doses. So I think we note that, but don't, make too big of a deal about it. I think that for some of our patients, though, it's pretty obvious when they're requesting their gabapentin refills early, or they're losing prescriptions, or they're just on really high doses, that those are times that, we work with the primary care provider if that's not us, or if we are the primary care provider, that we worked on tapering plans.
No, that's a good comment, too. Tapering is important. You can't just abruptly stop. There's cases of withdrawal with gabapentin, and I've seen it clinically in individuals that stop very high doses. A lot of people that are prescribed it, though, are on, off, abusing it, binging, running out, and so, in individuals that are prescribed it, that are abusing it, not all of them need to taper, but good. Thank you for your comments. We've got one other quick case and then one that our addiction fellow is going to present as well. So 2 other short cases. Before we change PowerPoint slides, I'm going to present one last case. I've got a 32-year-old with complications from an epidural abscess. She had been in another hospital, another area of the state, hospitalized with fever, neck pain, weakness, ultimately found out to have an epidural abscess, had a long hospital stay with a variety of complications, and ultimately was let out after completing antibiotics. She was placed on Suboxone, and she was actually followed in an emergency department bridge clinic because she couldn't get to the treatment program and had gone into the ED after the hospital, and they identified it. This is clearly a problem. If you go back to using IV, we'll put you on Suboxone. One of our medical toxicology colleagues had worked with her, and she's on Suboxone checking into the clinic, but is supposed to follow up with neurosurgery there and have additional procedures from complications from the epidural abscess, some erosion of the vertebral bodies, and she wants a second opinion, so she drives to this area and sees a neurosurgeon here who identifies weakness and ataxia and acute abnormalities and symptoms that they feel require emergent surgery. So from the clinic, she's sent into the hospital for a fairly large procedure involving stabilization, hardware implementation of some of the C-spine vertebral bodies. She had taken Suboxone earlier that day, and I'm wondering if anyone has any thoughts on what are you going to do for the pain, procedural, surgery. Is there anything how would you approach this patient postoperatively? This is a large portion of the consult service is helping with the buprenorphine management and manipulation of the buprenorphine or buprenorphine and other opioids. Does anybody have any comments or thoughts? What about Henry? If this is one of your patients and they call you for recommendations about post-operative management, one of your bupe patients, what are you going to tell the neurosurgeons or anesthesiologists?
Yeah, I guess I'd say, as part of kind of the, we have a pain protocol that includes ketamine in the post-operative setting. So for us, at least, I think we would encourage the use of that to start with. But regarding, management of opioid medications, I think that, we basically have 2 options at this point. One would be to continue, I suppose we have 3. One would be to continue giving her daily dose of buprenorphine, but then also give her kind of a PCA or some other, high-dose opioids on top of that. The other would be to just DC the Suboxone and, treat her with full agonists and hopefully plan to get her transitioned back to Suboxone afterwards. The third, which, given a fairly extensive surgery of just kind of splitting buprenorphine, increasing the dose, using Buprenex, so using only buprenorphine for pain is probably suboptimal given the significant surgery that she's undergoing. So I think probably either option 1 or option 2 of stopping the Suboxone entirely, or option 2 of Suboxone plus full agonists is what I would, encourage them to pursue, with the understanding that she's going to need high doses either way due to a high tolerance or due to some degree of blockade from the Suboxone.
Good. And thank you. Those are good comments. Any other thoughts or questions? Holly, if you have a patient on Suboxone and it has emergent surgery, how often are you contacted? Or do you feel that the surgeons or ED are reaching out for help? Let me unmute you if I can find you again here. 1 second. I think Dr. Russell dropped off. Elena, are you with us from Emory? Dr. Steck? Ingrid, how about you're working with some of these patients? I know, are you getting calls from the surgeons if this happens?
No, I work mostly in an outpatient environment, so I don't do inpatient consultations. Oh, sorry.
So this patient was given an extra dose of Suboxone and taken to surgery. You know, for the cases that we get involved in, and there's a lot of them, you know, we work kind of in conjunction with the acute pain service, is to help decide whether or not to continue the dosing of buprenorphine pre and post, and then acute pain often gets involved if there's the epidural or nerve blocks or specific PCA dosing. And this patient was just kept on buprenorphine, as most of the patients now that are coming in try and do with full agonists on top. It was, as Dr. Svoboda had mentioned, this is a big surgery. Patient did well, though. She was kept on 4 milligrams. She had a lower dose. We bumped it up to 4 times a day instead of the just 1 8 milligram dose at once. And she had a patient-controlled analgesia, PCA option afterwards of 0.5 milligrams hydromorphone Q10 minutes, and did really well with this while getting the buprenorphine, the Suboxone. Was only on that for about 24 hours, was working with physical therapy. She had a fairly extensive procedure involving stabilization and hardware implementation. And after the PCA, she was put on oxycodone on top of the buprenorphine for about 48 hours, 10 to 20 milligrams Q6 hours. I think mostly just got the 10 milligram dose. This is on top of nonsteroidals and acetaminophen. And on day 3, the oxycodone was taken away, and she was just given an extra 4 milligrams Q12 hours as needed, and did really, really well with pain control and progressed through the levels of care quicker than what you know, I would have anticipated. But later in the stay, while still on just the Suboxone, doing well and recovering, she admitted that she was really concerned when she got out of the hospital, was doing really well, that she, without structure and monitoring, was trading the Suboxone for cocaine, and so ultimately was set up with a methadone, an opioid treatment program to follow up, switching to methadone for daily check-in. And it was possible that the opioid treatment program was going to be able to do daily dispensing of buprenorphine from the window, but that wasn't confirmed. So despite it working really well for analgesia and in the hospital, she had another reason at the end to consider not continuing it. If there's no other comments or questions, we've got one other case that our fellow has. Sandra, can you, I sent you a second PowerPoint. Could you upload that second PowerPoint if you're still with us?
Sure.
If not,
yep.
I'll just, yeah, thank you. And then we're going to switch to Dr. Malko. She's going to present a final case. We've got a couple of others that we're going to save until next time, involving benzodiazepine dependence and withdrawal, and you know, another pain treatment case.
So the file you sent me, Tim, is listed as .key. I'm not sure if that will work. I've never heard of that kind of file.
Let me just open it up and we'll do it. I think we can do it from my screen. I'm not sure.
I can export it as a PowerPoint real quick. Sandra, what email would you like me to send it to?
Just my work email, sandra.kirilovich@acmt.net.
Here, reply to this. There you go. You're just reply to the email.
Okay. While we're getting this uploaded, I'll just introduce myself. My name is Jade Melko. I'm the new addiction medicine fellow. I'm working at University of Rochester
I'm also EM faculty. So I'll be here with you guys this year. Let's get this over. The case that we're going to talk about is a case that got brought up from one of our psychiatry faculty who sees patients in the outpatient setting on Suboxone.
This is the third year. This is the third year we have a addiction medicine fellowship. It's jointly hosted between the Department of Psychiatry, Addiction Psychiatry, and Emergency Medicine. Our first fellow was a former EM resident, now faculty, medical director of a treatment program, and our second fellow is also emergency medicine, primary trained, just started her fellowship. So Jade, the case.
As we're getting this uploaded, I'll kind of just start walking through the background so we don't waste much time. So we have a 52-year-old female who has been maintained on Suboxone for several years for both opioid use disorder as well as chronic pain. She had come into the clinic around January complaining of some new bilateral, mostly lower extremity pinning edema, although was noted to kind of involve her hands as well. She had mentioned that it usually is present in the morning but worsens throughout the day. The Suboxone doses that she has been prescribed had been kind of tapered a little bit per patient request, but this was a new finding on her exam. Also, the swelling had started in January, but in February it was also started on a new medication, which was Lyrica. And we'll go through her med list in a second, but her history is also notable for some travel to Antigua a few months ago, and she had mentioned to us that she had stopped her Suboxone and Lyrica at the time because of issues with filling the medications, and by the way, her edema had actually improved, and that was just something she mentioned to us in her clinic visit. So when we brought her back into clinic, we said, well, maybe we can try just putting you back on buprenorphine alone and see what happens, but unfortunately her edema recurred. So her medication list is actually up to date as of last month, but she had been tapered down to buprenorphine alone, 8 milligrams daily. She's also on gabapentin for pain, as well as Lyrica. And then additionally, she has hypothyroidism, and her PCP kind of conjointly had started her on some diuretics, both combination therapies and Lasix, and neither of those had seemed to help. So kind of with her PCP and us kind of thinking about causes of peripheral edema in this patient, the PCP had kind of directed a workup to rule out other causes such as CHF. She had a normal echo. Her chem panels and metabolic panels showed normal liver functions and albumin, but just making sure that we're not missing any renal dysfunction or things like that. The bilateral nature makes DVT less likely, but she was scheduled for outpatient ultrasounds, and then common things like venous insufficiency, but we couldn't help but think, could the medications be causing some of her symptoms? So, yeah, so we can talk about, kind of go through this at the end, but when we kind of think about side effects of Suboxone in general, reviewing them, patients will bring these up, but peripheral edema didn't seem to be on a common list of things that that were caused by Suboxone directly, or at least in the literature, that was kind of hard to find. So you can go. So common side effects of Suboxone that we see in our patients, most commonly are headaches, headaches, lightheadedness, insomnia, a lot of GI side effects, local reactions within the mouth, stomatitis, irritation, hepatitis, so certainly making sure we make sure the patient's peripheral edema isn't related to an adverse reaction in that regard, adrenal insufficiency, other things like drowsiness and withdrawal symptoms are not so much a side effect, but kind of just an adverse reaction of either overdosing or dosing too soon to use. So that being said, kind of reviewing, could this be the Suboxone or buprenorphine? There was not too many cases that we could come up with that would point us in the direction of Suboxone, so we had to think about other medications. How do I go forward? Sorry. So kind of reviewing post-marketing experiences that Suboxone actually published is that the most frequently reported adverse event that was not observed in the original clinical trials was peripheral edema. Not quite clear what the mechanism was, and was hoping to kind of talk to you guys briefly as we wrap up today about if you guys have had experiences with your patients reporting this edema. I found one case report from France that actually talked about switching from Suboxone to buprenorphine alone, although this doesn't quite make sense to me from a mechanistic standpoint. Other things that cause peripheral edema, I mean, many medications, including calcium channel blockers, antihypertensives, gabapentin, Lyrica, there's a laundry list of things that can cause peripheral edema, but this patient's timeline kind of argued against Lyrica being the inciting event. But what are, I mean, kind of talking about, could this be from the Suboxone? What are possible mechanisms that maybe peripheral edema could be from Suboxone? And then what could we do for this patient as we navigate them in clinic from our perspective as the PCP continues to work with them?
Maybe what have you seen in your patients on buprenorphine? Ingrid, you have your hand up. I'm going to unmute again. Is this a common side effect? What do you think about edema in this patient?
Well, it's not a common side effect, but I was just going to share that I certainly in our practice have had a few patients who have complained of peripheral edema, and it's been puzzling because again, when you do the search, you don't come up with very much. Some of them may have had some other reasons for it because they were older. So I've had a couple of men. The other one have been mostly women, and often fairly youngish women. You know, they're in their late 30s. Maybe the oldest one was sort of in their early 40s. And so I'm puzzled. I have no idea what the mechanism is, but I'm just sharing that I have had that experience and have had a few patients, complain of it. It's either been tolerable or we've looked at decreasing their dose. They're usually on the Suboxone, so the buprenorphine naloxone combination. And we didn't really think about switching them maybe to another formulation that didn't have the naloxone in it. Your patient was just the other way around in terms of that case from France that you reported. And for other patients, it was fairly, it did sort of okay. A few people have had a little bit of facial edema as well, but they've complained kind of around their eyes mostly, which is a bit odd.
Now, this is something that I've heard others mention, but I've not really seen in patients in many years of not prescribing buprenorphine, when I can't explain it by other reasons. I mean, I've seen it in the detox setting where people come in and often get very high salty food and then puff up and have edema, but they're also often taking non-steroidals, and I don't see that necessarily is related to the buprenorphine or Suboxone that goes away when the food changes and the non-steroidals stop. All opioids potentially can have some SIADH effect, and holding on to extra water could be a mechanism, I suppose, with buprenorphine. I see a lot of side effects that are reported with the dual product that I'm skeptical about and are sometimes secondary motivation to try and get the mono product, the buprenorphine. but the edema I don't often see. Maybe Liz, do you have a comment?
As we're trying to unmute you, Liz, and Dr. Regan had mentioned that kind of salt retention and shifts in water are one mechanism for peripheral edema, but when looking at like gabapentin and Lyrica, one of the things that I kind of stumbled across was similar to calcium channel blockade. There's a suggestion that the peripheral edema can be from arterial vasodilation and kind of the combating forces causing the edema, and there was thoughts that if you can't taper, trials of things like ACEs and ARBs, as well as kind of periods of pulsing nitrates might be able to help with venodilation, but this is all kind of skeptical.
That's interesting. That's great. It sounds like, so what was the end with this? Did you continue the buprenorphine or buprenorphine naloxone and just tolerate the edema, or?
So she's still continuing her workup as an outpatient for other causes. She's being tapered down on Suboxone, kind of with her plan. She's planning on traveling again. So I think ultimately, hopefully this will resolve, and if not, it's also a good opportunity to consider kind of tapering gabapentin and Lyrica as well, because those are side effects, and kind of using this as a time point to kind of pause and reevaluate all of our medications, because this is probably polypharmacy, whether or not we ever figure out exactly which one it is.
Thank you for presenting that case. We're at 90 minutes. We're just a little bit over, and I think we'll end here. This is recorded. It goes up on the ACMT website. If you're interested, it should be accessible to everyone. If anyone has any cases that they'd like to hear, that would be great to send the cases, and we can put them together in advance. We're not going back and forth. I would love to have some additional presenters. So just let me know, email me, and if you have any other thoughts or comments, please reply. Our next third Friday conference is in August, the third Friday in August, again, 1:15 Eastern Time, and thank you all for attending. We had a great audience, great number of attendees, so any comments, let us know, and have a great weekend. Thank you.